Good morning. This presentation is going to review general health and population indicators. You can find this information in Chapter 6 of your epidemiology textbook. Our objectives today, I'm not going to go over them specifically. And the means of measuring health statistics are varied. So from 2000 through 2016, the global life expectancy increased by 5.5 years. With the World Health Organization African region showing the greatest increase of life expectancy with an increase of 10.3 years. So there are a lot of different factors that influence and contribute to the health of individuals, communities, and nations, like behavior choices, environment. It can be something as simple as clean water that can definitely have an impact on the overall life expectancy. Other health indicators, it's a marker of health status. It can be physical or mental, impairments or disabilities, and social well-being, service provision or source availability. So examples are health resources, collective justice, social capital, collective capacity, resiliency, and functionality. So some common indices used to identify the health status of population. Descriptive epidemiology uses several, and these indices are typically related to births and deaths because such data is more available. Health indicators tend to involve data that are required by law, like death certificates, hospital discharge information, and notable disease registries, because we take such great risk at preserving the patient's or the person's confidentiality. So sometimes those statistics may not be readily available because of that. An example of a health indicator graph on life expectancy we'll see here, followed by fertility and mortality. So here is a graph, life expectancy. This one is narrowed down to Hispanics, Hispanic origin, race, age, and sex in the United States. This one is 2015, so this is a 10-year-old graph. I'd be interested to overlay 2025 on it to see if it had changed. Okay. And here is fertility rates and birth rates. You take the number of live births during a specific period and divide it by the population from which the birth occurred and multiply it by 1,000. The fertility rate equals the number of live births during a specific time period divided by the population of women 15 to 49 times 1,000. So you need to know algebra to be able to do that. All right, here's a comparison of selected total fertility rates in 2017. So this one's a little bit newer, 2 years newer. And you can see here, well, Niger in Africa, look at that, average births per woman, that's 6.5. Wow. Let's look here at some other places. We'll look at all the way down here in Singapore. It doesn't even reach 1. What's that all about? Interesting. But you can see it looks like the average person across the world, and United States statistics aren't on here, have about 1.5. 1.5 to 2 children. Here's an example of proportion of contraceptive prevalence. So the prevalence is defined as the proportion of women of reproductive age who are using a contraceptive method at a given point in time. The methods of contraception vary considerably throughout the world. So in the United Kingdom, contraceptive prevalence is 84%, with 8% of women being sterilized, 21% of males are sterilized, and 28% are on the pill, 27% male condom, 2% rhythm, and 6% withdrawal. In Nigeria, contraceptive prevalence is only 13%, with 0.2 female sterilization, 0% male sterilization, 2.3 on the pill, 1.1 male condom, 1.0 rhythm, and 0.9 withdrawal. So that could definitely relate to the fact that they have a higher birth rate there, right? In Pakistan, contraceptive prevalence is 35.4, with 8.7 female sterilization, 0.5 males, 1.6 the pill, 8.8 male condom, 0.8 rhythm, and 8.5 withdrawal. Let's look at mortality, the most common cause of death other than heart disease. And it's kind of hard to see on this slide. At least my view is, it's not real clear. Maybe your view is a little clearer. I can't see too well. It looks like in Illinois, is that stroke? On my big screen, it's blurry. On the little screen, I think it was a little clearer. So mortality is the epidemiologic and vital statistics term for death. And in our society, there are generally three things that cause death: degeneration of vital organs and related conditions, so old age, disease states, or society of the environment, like homicide, accidents, and disaster. So those are the three different categories of mortality. All deaths are recorded and reported to the local health department, and reports of vital event statistics like deaths are reported to the National Center for Health Statistics. And legal authority for the registration of births, deaths, marriages, divorces, and fetal deaths resides individually with the 50 states. Washington, D.C., and the 5 territories, they're separate. So the United States is a republic. So the states govern themselves. They're supposed to make their own, policies and stuff like that. It is overseen by the federal government, but in a republic, things like health statistics and public aid and dispersal and things like that, it's managed by the state. And the vital statistics registration system in the United States measures these things. The laws of each state provide for continuous and permanent vital registration system, and each system depends on the conscientious efforts of physicians, hospital personnel, funeral directors, coroners, and medical examiners in preparing or certifying information needed to complete the original death records. And I know when I worked in Women and Infant Services, I was the nursing director there, they keep track of every birth, every fetal death. We had 2 maternal deaths while I was there. And that's a big deal because it's not very common. So they really do root cause analysis to identify the cause. Most of the time in women, it is a pulmonary or amniotic embolism, which I don't know if it's changed because I've been out of that field for a while, since 2009, when I began to focus on family, but there's very little you can do for that. Death certificates include the following: date of birth, age, gender, place of residence, occupation, marital status, and other information like injury, place, time, cause of death, if it was a disease or initiated by a set of events. The main cause of death is entered first, but there may be some existing conditions that contributed to it, and those will be listed as well. And this is how they come up with the death rates: a crude mortality rate, a cause, and an infant mortality rate. It's all this dividing and multiplying by 1,000. Here's some more: neonatal mortality, post-neonatal mortality, and that is 28 days of age to 1 year. Perinatal mortality, these are infants 6 days of age or younger. They have different phrases for the different ages of the infant. Neonatal and postnatal mortality rates by racial groups in the United States, and this is between 1983 and 2015. So that's a lot of data. A lot of data. And fetal death rate, how they come up to that. And to determine the fetal death rate, the fetus must be at least 20 weeks of gestation, at least 20 weeks of gestation. And the abortion rate is the number of abortions done during a specific time period, so divided by the number of women aged 15 to 44 during that same time period. I don't know how they come up with 44 PIP. There are some women who are fertile after that. And maternal mortality rate, number of deaths due to childbirth during a specific period, and the number of live births in that same period. So gratefully, the maternal mortality rate is low, but it does happen. Okay. So estimates of maternal mortality rate, that's MMR, by 100,000 live births. And let's see, in developed regions, it's 12. Developing, in the world, it's 216. Interesting. And they go down to specific regions. Sub-Saharan Africa. Look at that. That's a lot, I think. 201,000 maternal deaths? Really? Okay. And this is how they come to that. And here's a hypothetical example of the calculation of proportionate mortality rate. So we have two cities, each have a population of 1 million. So let's just say that, put that on the table. The death rate from all causes in the metro city was 400 or 40 per 100,000. In the suburban city, it was 900 or 90 per 100,000. Cancer deaths in both cities were 4 per 100,000 or 40 deaths per city. The risk of a cancer-caused death for both cities was the same. If calculated according to the formula on the previous slide that we saw, the percent of all deaths from cancer is the proportionate mortality ratio. So for each city, the PMR results would be as follows. The metro city, 40 divided by 400 times 100 equals 10%. In the suburban city, it's 4.4%. So the overall cancer rates in between the metro and suburban city, the suburban city has a lower proportionate rate. Death to case ratio, this is defined as the number of deaths attributed to a particular disease during a specific time period that's divided by the number of new cases of that disease during the same time period. So this is to measure the various aspects of properties of a disease. And I keep going back to COVID because it was so prevalent back then to try to identify death rates. And it's often used in studying poisonings, chemical exposures, or other short-term deaths not caused by diseases. It's not really useful for chronic disease. So in Connecticut 2015, the death to case ratio of pancreatic cancer was 77.1%. That's, well, pancreatic cancer is not an easy cure. So does that statistic tell us anything? I don't know. The case fatality rate is defined as the proportion of persons with a particular condition who die from that condition. This is more, this tells us more. So in order to calculate, the denominator is the number of incident cases and the numerator is the number of cause-specific deaths. So let's look at this example. In April of 2003, the case fatality rate of severe acute respiratory syndrome, or SARS, was 13.2% for patients younger than 60 and 43.4% for patients 60 years and older. So you can see there's definitely a difference in age, quite a bit of a difference. I'm curious to see, because this is an old statistic again, how this rate has changed. Because I know the treatments have changed. It actually was the ICU nurses that identified that SARS patients did much better when they were on their sides and their stomach and not on their back. And that's one of the reasons that treatment was put in place when COVID was at its height. That was one of the instructions I gave all of my COVID positive patients. I still do. Even though the cases of COVID that I have seen over the past month, they're mild, they're more like a bad cold. If you have comorbidities, like I have severe asthma, I have an N95 when I go into any patient's room that's got a respiratory issue. Because if I get it, it's going to hit me and it's going to hit me hard. Years of potential life lost is a measure of the relative impact of disease of health-related states of events on a population. So this is something that is considered a measure of public health related to the value of human life. It has an economic implication of the loss of individuals of society. It quantifies premature mortality. For example, a 20-year-old male could theoretically have lived to about 76. Thus, 56 years of life are lost. When 1,000 deaths like this occur in a given population, 56,000 years of potential life are lost. And that's looking at this at a totally different perspective, right? Years of life lost. It really, I think, even though the loss of life is at 20 is a horrendous event, this actually makes it even more so. Improvements in life expectancy can cause the increase in an available workforce, which in turn benefits society by productivity, right? And what is the number one cause of death of people around that age, right? Accidents. They're more reckless. They take more chances because they have that. If you think about psychology, they still have that thought process in place that they're going to live forever. So they take more risks. As they get old and they realize that that's not the case through life experience, the risk that they take becomes smaller and the life expectancy increases.